ceremony for the girls to name them, but they do not, of course, do circumcisions. Just one more information. Okay, all right. Here during the fourth stage. So with the perineal discomfort, the best thing to do is ice, especially for the first 24 hours. So we try to get ice on these moms' perineum as soon as we can after delivery, because that helps with the swelling, and it also eases that area, which helps with the pain. After the first 24 hours, heat's good to use. So they can do sitz baths, which are these little basins, and they kind of they put the toilet seat up and they set them on the toilet and then put warm water in them and sit in those, and that's very soothing. Highly recommend it. Highly recommend it. At Rowan, they don't really have a sitz bath that they give, but they do have they have bathtubs, and so they fill up, warm water in the bathtub and have them sit on that. Yeah, not my idea of a good thing either, but it definitely, the heat, of course, decreases the pain also, increases circulation, and of course, we also give moms, anyone who has an episiotomy or laceration with repair, dermoplast spray, which you guys all looked up. So we instruct moms to use a little peri bottle, fill it with warm water, and each time they go to the bathroom, spray themselves off. It's very important for them to keep clean, right? Because they are at risk of infection. We've got that raw area where the placenta was, and very, can be a port to an infection setting up. So then there's also the tucks. Also, witch hazel tucks that you can put on the peri pad, and that kind of hits that area too, and is soothing. So those are the instructions we give moms for that. We already kind of hit on suppression of lactation. So again, wearing the tight bra, supportive bra, sports bra, applying ice packs, and avoiding any stimulation for our non-lactating moms. Avoiding heat. They used to give medications to dry up the milk, and they no longer give them. Anybody give the rubella vaccine to any other moms? Yeah. So they can't receive it. They test them. Struggling to talk. They test the moms when they come in for their first prenatal visit, and if they're rubella non-immune, so we're looking to see if they're rubella immune or non-immune, okay? Or they'll say rubella positive or negative. We want them to be positive because then they're immune. But they cannot get that vaccine until after they deliver. Okay, so that's after they deliver, before they go home. If they're rubella negative or not immune, then they will get the rubella vaccine. The big instructions that we need to give our moms is not to get pregnant for 3 months, okay? Because it can be passed on to the fetus. So 3 months. Another vaccine, yes.
How long do they usually wait to tell them to get pregnant anyways?
Well, we don't like them to get pregnant right away at all.
Right.
But as some of you probably know, somebody that it's happened to, your body has to heal. So we definitely don't want them to have any sexual relations until 6 weeks. And by that point, the healing is pretty well on its way. But, that uterus is still not ready for another baby. So I'm not sure, I can't really give you a month or whatever, but, preferably a year, I would say, at least a year. I'm not sure. And how soon do we need to give the RhoGAM for our RH?
72 hours.
72 hours, very good. And we'll talk more about discharge instructions down the line. complications. And of course, ideally, vaginal deliveries are the best way to go. But sometimes, as you see and know, some babies have to be delivered by cesarean section. So they're at risk, they're at all the risks, in addition to having a baby, that anybody with surgery has, right? So they're at higher risk. If rupture of membranes has been longer than 24 hours before the baby delivers, what are they at risk for?
Infection.
Okay, very good. So they're at risk, higher risk. Just a prolonged labor can also put them at risk for complications. Anytime you get a bladder, a Foley catheter, bladder catheterization, puts you at risk, right, for a UTI. And then everybody's at risk for hemorrhage. Okay? Mastitis, they can get upper respiratory infection, UTI, thrombophlebitis. And what assessment do we do to assess for
Home and son.
home and son, right? And we want it to be negative. So what's the best intervention we can do to avoid?
Get up and about.
I'm sorry, get up and move them as quickly as we can. So like with our C-sections, they've had a surgery, but we try to get them up in 12 hours. Get them moving. And definitely with our postpartum ones, that's what, when you guys say, there's some of these cultures that have them in bed for 6 weeks, I'm like, how many of them have blood clots? That's what I always think of when I hear that. But I guess you don't see too many complications and them not moving around too much. But yeah, that's what I really know. And again, we're going to be checking the perineum, and we're going to get into more of that, for hematomas or abscess formation, endometritis, and perineal cellulitis. Okay. So we need to talk a little bit about differentiating between what is considered an early postpartum hemorrhage and what is considered a late postpartum hemorrhage. So an early postpartum hemorrhage, as it says on the slide, is within 24 hours after birth. Anything later than 24 hours after birth, but less than 6 weeks, is a late postpartum hemorrhage. What are we going to see? Just as expected, excessive bright red bleeding. Again, the fundus, everybody know what boggy means? So we're talking about boggy, where the uterus is not firm, or not. She didn't talk about that. Okay, that's what we call the fundus when it's not firm. We call it boggy. And that's when we're going to massage that fundus and try to get it to warm up. Because a lot of times just massaging it will help. And we'll talk more about what we can do if that doesn't work. But what if the uterus is firm, where it should be, in the right place, not off to the right, right where we expect it to be, and there's still bleeding? What would we suspect? Laceration, very good. Of course, with hemorrhage, you're going to see an increase in their pulse and a decrease in their blood pressure. They also might have a hematoma, which we've been on a couple times now. So that's why, and I don't know if you saw that some of your nurses didn't check the perineum. Now, we don't have to check the perineum on our C-section moms, but on our vaginal deliveries, they need to be rolling over so we can see their perineum, because they could have a hematoma. And sometimes you can't see them, so if they have a lot of unrelieved pain, you've given them a bunch of stuff, and the uterus is where it should be, it's a process of elimination. Perhaps it could be that they have a hematoma. It's just unrelieved. And worst case scenario, they start to lose level of consciousness. So what causes early hemorrhage, early postpartum hemorrhage? Uterine atony. That uterus just is not clamping down. woman's body. And this is the number one reason moms have early postpartum hemorrhages. Like 90% of all our early postpartum hemorrhages are due to uterine atony, or that uterus just not clamping down. Another reason is lacerations. And again, you're going to see this when your uterus is nice and firm, it's where it should be, but there's still trickling blood. Okay, that's when you would suspect they may have a laceration, and you call it up. Another thing that can happen, yes.
I was going to ask you, what if the woman has just bleeding? Would that be something that you think would be corrected prior to her getting pregnant or this pregnancy corrected? Do you think that's something that would possibly benefit itself?
Are you talking about DIC or something like that? Oh, you mean you have difficult periods and that kind of thing? The pregnancy could maybe straighten it out? Maybe. I'm not sure. I'm not sure if it normally does. Anybody have any experience with that personally? I do not. I'm not sure. Sorry about that. Can't tell you that. So, as I said, a hematoma, I don't have that up here, but add that to this slide. And a hematoma is usually the result of injury to the blood vessels from a traumatic delivery. Okay? And there's just inadequate clotting of the blood in that area, and it just, becomes a hematoma. It can be at the incision, it can be at the episiotomy, or laceration. But it's usually due to a traumatic birth, large baby. So, who are at risk of this? High purity, okay, or multi-parous. Moms that have a lot of babies have stretched that uterus out several times. Well, it's the muscle, and the muscle that gets stretched out has to work a lot harder to get back down. So those are the ones we really watch closely. The more babies they've had, the more risk they are of having bleeding problems because their uterus just is stretched out and can't clamp down on that placenta area. Any other reason that causes the uterus to be large also puts them at risk. They've stretched that muscle out again. So like hydramnios, I think this word probably talked to you about that, polyhydramnios or hydramnios, too much amniotic fluid, or a large baby, macrosomic, we call large babies, twin pregnancies. I mean, anything that overstretches that uterus. Traumatic birth. Anesthesia. If they had to be on mag sulfate, you guys talked about mag sulfate with preeclampsia. That is a muscle relaxant, right? And, it stops labor typically. If they had to be on that during labor because they were preeclamptic, their uterus is not, it's used to being really relaxed, so they're at more risk from not being able to clamp down. A rapid or prolonged labor, chorioamnionitis, which is an inflammation or infection of the chorion and the amnion, and use of Pitocin. So the use of Pitocin, it has told the body contract, 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 contract. Well, any muscle can get wore out, so it's kind of like that muscle is tired of contracting. So that can put them at risk. So, hemorrhages can occur from just a slight trickle to an all-blown frank hemorrhage. Okay? So you want to investigate all the sources that it may be, as we talked about. It may be partial or complete hemorrhage. Not partial or complete hemorrhage, sorry. That's next thing. Uterine inversion. Okay, so uterine inversion is where the uterus comes out, okay, and it may just break loose in the vagina, or it may actually all come out. And I had a couple students a couple years ago where it all came out. That's a big emergency with emergency surgery, and hopefully get it back in there, but typically, if that happens, they end up with a hysterectomy. Yes.
I thought that the uterine inversion was where it flips inside out.
It does. Yeah. So it's coming out.
Oh, okay.
So, yeah.
I thought that it was like internal. I was thinking of it different.
It can be internal, it can be in the vagina, but sometimes it can actually come out. So yes. So like the uterus excuse my it's a terrible drawing. So when it comes out, this part of it, the inside is out. So it's inside out. It's hanging out. That's a terrible picture.
So like the ligaments are still attached to the tubes, it's just the ball itself kind of flips.
Comes out. Okay, so what can cause big reason is if the doctors get antsy. Did anybody see that in the labor or in the delivery where they're the cord trying to speed up that placenta from coming loose and coming out? If that mom has had a lot of babies, there might be scar tissue up there, and it might adhere a little bit. And if they yank on that, it might pull the uterus out. So that's kind of a real no-no with our docs. So it's our multi-paras that this can happen. If they have just having a relaxed uterus can cause that, to just come out. So when you palpate the fundus, how do we teach you to do it? You're going to support, right? That's the reason we're going to support down here, because we don't want to be the cause of that. And sometimes they have to, I don't know if you saw that in labor and delivery, where they really vigorously massage that fundus right after delivery because they really want it to clamp down. But they got to be careful, because if you're too vigorous, you can push that uterus out. So you always want to support it while you're massaging it. Yeah. It's tender. It's tender. Yeah. They want to make sure it clamps down real good. So, that can happen with vigorous bundle pressure, excessive traction of the cord, uterinectomy. If they have leiomas or little tumors in their uterus, and abnormally adherent placental tissue, if it just abnormally just won't let go of that uterine wall. Again, it happens in our multi-paras. Okay, talked about that. So these docs need to be very patient with that placenta. Okay, so that's our early. Our late is our subinvolution, which again is the failure of that uterus to return to normal size. What are you going to see? You're going to see the lochia rubra come back where it had gone away, or rubra lochia that lasts longer than 2 weeks. If there's an infection, so signs of infection, fever, backache, foul lochia, we always want to tell our moms to make sure there's not a foul odor to their discharge. And sometimes this isn't found until the 6-week checkup. Okay, that's another reason why they do the 6-week checkup, to make sure that uterus is getting back down into the pelvis. At this point, they probably just use Metrogen, which is also an oxytoxic, like Pitocin, but it can be given by pill, so that's typically what they will give them to try to help. Now, if the late hemorrhage, when does late hemorrhage happen? After 24 hours, or less than 6 weeks, right? Yeah. So, if there's fragments of the placenta that, are missed, that the doctor doesn't notice that part of the placenta did not come out, They may have to do what's called a DNC, dilation and curettage. They don't like to do this. They try the methogen first to see if it will work itself out. But does everybody know what a DNC is? A dilation and curettage. They dilate the cervix and then they go in and scrape that area. So that's the last straw kind of thing. And it also, as we talked about, can be due to infection. So endometritis is where the endometrium of the uterus becomes infected. And that's usually, where the placenta fuse. So those are your late hemorrhages, late postpartum hemorrhages. So management. Of course, if they're off to the right, we're going to get up and have them go to the bathroom, empty the bladder. Then the next thing is we're going to be massaging that fundus. Okay, trying to get that to firm up, and a lot of times just massaging it, and that's exactly what we do on the outside. We just massage it, rub their uterus, and it'll make it clamp down. And hopefully push out anything that needs to be pushed out. So you might see some clots when you're doing this, but hopefully that'll bring it down where it needs to be. Then if their bladder's empty, we massaged and it's not helping, that's when we get the medications out. Pitocin, if they've got an IV, methogen, PO, and the last resort is Hemabate. And that is a prostaglandin that causes muscle contractions in the uterus. So we're assessing for signs of shock. So what would we be monitoring?
Blood pressure, pulse.
Vital signs, definitely. Yep. We're watching the urine output. They may be thirsty and pale, and definitely low blood pressure and headache. So they will treat, definitely we will keep their IV if this happens early. Hopefully they still have an IV. With our C-section moms, typically they leave a saline lock-in so they can, if something goes bad, they can just without the IV. But with our vaginal deliveries, a lot of times they don't have an IV, so we would have to put an IV in. So with lacerations, they'll be sutured. So they'll give them anesthesia and suture the laceration. And hematomas, depending on how large they are, may use ice at the perineum, or they might have to go in and ligate them and fix those bleeding vessels. Puerperal infections or postpartum infections, endometritis is your number one. Then there is parametritis and peritonitis. So of course, endometritis is the lining of the uterus infection. Parametritis is pelvis, and peritonitis is the perineal cavity. What are you going to see? Fever, tachycardia, chills, anorexia, nausea, fatigue, pelvic pain, uterine tenderness, and foul-smelling lochia. So typically these are streptococcal or Staph aureus are the common organisms. And endometritis is the most common and begins at the placental site and moves to the endometrium. And the route is through the cervix. So that's why it's really important that these moms keep their perineum clean. So I encourage them to spray off every time they go to the bathroom, pat dry, get a new pad, do the spray and the tubs. Peritonitis occurs when there's an abscess in the pelvis. And this will cause, of course, severe illness with a very high fever, abdominal distension, nausea, vomiting, and changes in vital signs.
Is it active in the blood?
Wound infections, you guys know all about wounds, incisions, we check in the burrito, any redness, edema, bruising, warmth, drainage, tenderness, separation, fever, and pain. So then these can develop, of course, in our C-section incisions, our episiotomies or laceration sites. If it's an incision and the infection has an abscess in it or it's internally infected, sometimes they'll open up the wound. Have you guys seen an open wound healing from the inside out? Secondary infection.
Like the lay back guy was moving, remember? That was
Well, but that wasn't yeah, but it was just because of the whole thing. Yeah. That's when they open it up. It's open. So if you ever have a ruptured appendix, they usually leave it open and they pack it, and then it heals from the inside out because you don't want to close that up, right? You want to open it up so that infection can come out. So if they suspect that that there's a abscess inside that incision, a lot of times they'll just open it up and then they'll pack it, and each day change that, and then so it'll heal from the inside out.
But she said that was a C-section, and it didn't look the same as the first one.
Yeah, hers looked kind of funky. Yeah, it looked, but I think it was okay. It just looked like it had just happened. It's really red, kind of like that tissue was just really fresh. It didn't look like it was healing. Okay. And then once the healing's occurred, then they'll close it. Once the infection's out of there, then they'll close it. So that's just, I got to get that myself. So we usually do the packing like 2 to 3 times a day. Of course, they're going to be on antibiotics. What's that? I'm so sorry. I was hoping nobody heard it.
That was loud, but no one said anything. Maybe
I heard it.
Sorry.
That's okay. I'm sorry. Okay. Well, we got to get through this, so hang in there. All right. We also want our moms definitely to wash their hands frequently and change their linens every day. And what kind of diet do we want to encourage them to have?
High protein.
High protein. Vitamin C. Very good. So fruits and vegetables and good healthy meats. And if their hemoglobin is low, red meats, liver, iron, please. And a lot of times, as I've already said, I'm repeating myself a lot, but the labs, you can't really go by the labs, right? But if there is a 30% increase in the white count in a 6-hour period, then it's often indicative of infection. But if you just look at the initial white count, it's going to be a little high. But if you see like the next day that it's raised 30%, then it's more indicative of infection. Of course, pelvic rest, no tampons, douches, or sex. This happens late in the process. Going to give them pain relief and be checking for Rita. repetition is the key. Right? Very kind of this, but UTI is a possible kind of infection that moms can get. And again, excuse me, this is because the bladder tends to get over distended and they don't notice that urge to void. And what happens when you just have stagnant urine? It's a breeding ground, right? Warm, moist, all that good stuff. So that's a risk factor for moms. And sometimes there's so much swelling and pain, they don't really have the urge to void. So again, stagnant urine is going to cause a urinary tract infection. But they may present with backache, fever, and again, their bladder capacity is increased. They don't have the sensitivity to their bladder being full from the trauma. Catheterizations can introduce bacteria, right? We need to be very careful with our still technique. Hopefully you're all scarred for life on how to do Foley catheters correctly. I remember that check off myself in nursing school. I mean, I was like, I never forgot that one. It's very important to keep that sterile. And then, if they don't have feeling after the epidural, sometimes that can also be a cause, or spinal. And E. coli is often the cause of cystitis, so what can that be from? Wiping incorrectly. So again, sometimes we're in the bathroom with these moms and we pick up on something like that, and nobody's ever taught them correct wiping. Yeah, hard to believe, but sometimes that's the case. So again, we're going to teach our moms how to wipe from front to back. How are we going to manage this? Again, frequent voiding. Pick them up, remind them to void every couple hours. It helps to get the swelling down and the pain, because sometimes they're in so much pain they don't want to move, I don't want to get up and go to the bathroom. So, pain control is really important. We have to catheterize them, sterile technique, and it may need to get a urine culture, and if it cultures 100,000 or greater, that's indicative of an infection. 100,000 or greater on a culture of whatever bacteria is indicative of an infection. Of course, we're going to give them antibiotics. Our sulfa meds are good go-tos. Bactrim and Septra, real popular. Ampicillin. Or antispasmodics, like we would give maybe pyridium. And then what do we need to tell our moms about that?
The color of their urine.
Colors your urine orange, don't be alarmed. And that helps with the pain and the spasms. Increase fluids, but preferably not soft drinks. Cranberry juice, they still feel is a good thing. Any of those acidic juices. Yes, Ashley. I am. In the urine, yes. If they culture it and they get 100,000 or greater, that's indicative. So if you ever see a urine culture result and it says 100,000 of such and such, they have a urinary tract infection. And then they do a sensitivity too to see which antibiotic will kill that particular bacteria. So any of the acidics like plum, apricot, prune juice will help. Just drinking a lot of fluids. Water is good.
So basically no tea, coffee, soda,
Correct.
caffeine.
Correct. Yeah. All the things. But I would rather somebody drink that than nothing. But yeah. Discourage that, encourage more of the water and the juices, the acidic juices. Yes.
Yeah, that'd be okay.
Yeah. 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 always good to remind them that green peas. Okay. All right. Our other infection, mastitis, infection of the breast, and these moms are going to feel flu-like. They're going to have chills and fevers and just not feel good. And of course, they're going to have redness in their breasts and tenderness and swelling. So this can happen once the milk comes in and they become engorged. So the big thing is we need to tell our moms when their milk comes in, feed that baby. That's the best relief for the engorgement if they're breastfeeding. Now, if they're not breastfeeding, we're just going to bind them up and ice them down, and hopefully that's not going to develop into mastitis. But typically, mastitis is due to an opening in the nipple, fissure in the nipple. So that's why we're always checking mom's breastfeeding nipples for cracking, bleeding, all that good stuff. Typically, it's unilateral. Just gives them one breast. That's bad enough. So what happens is that the infection gets in through the broken area in the nipple and then gets into the ducts of the breast. And of course, milk is warm, so it's a really happy medium for bacteria to grow. It's very sugary. And if it's not treated properly, it can develop an abscess, and they don't want that. Sometimes abscesses have to be incision and drained, so we want to tell our moms if they see any redness, firmness, and they feel flu-like symptoms, to contact their doctor. The big thing with mastitis is you want to keep them emptying that breast, okay? Because if you don't empty that breast, it's going to make it worse. So unless the mom has an actual abscess, they should continue to breastfeed if they can. If they can't because it's so uncomfortable, they need to at least express somehow, just to keep your doctor said not to breastfeed? No, if you have an abscess, yes. So you can still breastfeed. Babies drain the breast better than any machine we have. So yeah, if you just continue breastfeeding every 2 to 3 hours is best. But if you have an abscess, of course you can't. You got the meningitis infection. Also, there can be yeast infections, so the doctor will need to figure out if it's a bacteria or a yeast infection. Because again, it's very sugary and a great environment for yeast to grow. So kind of already got into this, but frequent emptying, dead rest. So continue to breastfeed every 2 to 3 hours. Switch breasts, of course. Continue to switch breasts. NSAIDs are great. Our ibuprofen's great for pain. Lots of fluids, supportive bra, warm, moist compresses. Okay, we do not want to put cold, right? Well, you don't know that, I guess, but do not put cold. It is right. Warm is good because you don't want to keep that from resolving or coming out. So definitely no cold. That is
It's not comfortable.
yeah. Warm is better. Yeah. We'll just go with warm. With mastitis, they said cold. Yeah. Okay. Correct. If they're not breastfeeding, yes, ice. Does it say that? Which page are you on? 17. Oh, I'll verify. they'll be on antibiotics, analgesics, and again, no soap on the nipples.
Would you have the moms that aren't breastfeeding still empty their breasts because you want them to get rid of it?
No, because if they empty their breast, it'll keep coming in.
Okay.
So, and cabbage, bind them. They are not the typical people to get mastitis because, there's no introduction of bacteria because there's no cuts in the nipples or fissures or whatnot. So they're not the typical. It's our breastfeeding moms that are at risk for this. And of course, if it's determined to be a yeast infection, they'll be on diflucan. And again, good hand washing. Yes.
You say, do you go warm or do you go cold?
Well,
Are you looking at something?
Meredith? Deborah? Close. Deborah found it in the book, so I am going to clarify that. My recollection is no, you don't use cold. Okay.
Well, cold's gonna stop your milk.
Right.
Maybe it's not breastfeeding.
What doesn't help with pain? Okay.
So you're going to go back to page 727. You're going to reference page 727 and follow up with us.
Yes.
Okay.
727. Yes. So I'm gonna look that up. I'm gonna get it clarified. So that's what I've always believed.
Papa is saying, after a short draw, local application of warm, moist heat, or ice.
Or ice cream. Ice is good because it does relieve pain. Okay. And I guess a little bit of ice. I wouldn't keep ice on the whole time because we want to get that breast milk moving through so it's not stagnant in there. Someone out here, I want to say their name, said that the cold doesn't even feel good. The heat feels good. Okay. Yeah. So typically you're getting, when you get engorged and you're breastfeeding, a good thing to do is get in a warm shower and just express a little bit. Because sometimes when your milk first comes in, you're so filled that baby can't even latch on. So you kind of have to get in, you have to work that out a little bit and soften your breasts up a little bit so baby can latch on. So it's contradictory apparently. So I'll look into that. Thank you for pointing that out. Okay. Okay, do you guys need a quick little break to go the last half hour? Yeah. Or am I gonna? Okay. So, yeah, go ahead and take 5 minutes. Potty break. Recess for our thromboembolic disease. Can be superficial thrombosis or deep vein thrombosis. Superficial are those superficial saphenous venous system, and deep vein can extend from the foot to the iliofemoral region. With this, what do we worry about happening? What can this lead to? They have undetected DVT, PE, pulmonary embolism. Okay. And just to stop for a second and talk about that, what would we see? Everybody knows what a pulmonary embolism is, right?
Yes.
The blood has dislodged from the leg, gone to the lungs. So what kind of symptoms are we going to see?
Shortness of breath.
Shortness of breath. Pain. Chest pain. What would we check? If they were short of breath, we'd check
Pulse ox.
O2 sats, right? Vitals, okay? So their O2 sats would probably be low. Alright. So just be aware that that can happen. We had several folks on the joint camp that would end up with PEs that had no symptoms that we knew of. I mean, they had surgery on their knees and it's red and swollen. That happened to yours?
That happened to my fiance. Yes,
Okay.
he's like 39 years old.
Yeah,
Crazy.
they're at high
Knee surgery.
risk. They're very high risk for that. It's horrible, but yeah. So sometimes you don't know you've had a blood clot until it gets to it. Okay. Risk factors, of course, are our C-sections. They're not moving around as well. They've been put under anesthesia, so if they've had a spinal, they're laying still, all that stagnant blood. And if they've been put out, they're definitely shut down for a while. So that's why we need to get those C-section moms and postpartum moms up and moving. Also, patients that have varicosities in their legs are at higher risk. Obese patients are at higher risk. Maternal age over 35 puts them at higher risk. Multipara or multiparity, more than one baby puts them at risk, and of course smoking puts them at risk.
When you said the superficial, I've got the superficial saphenous venous system, and you said and something else, and I missed that second
And
part.
the deep vein are so the superficial venous thrombosis are in the superficial saphenous venous system. Yeah. And the deep vein can extend from the foot to the iliofemoral region.
Thank you.
You're welcome. So if a patient has been on antibiotics for endometritis and does not have any relief of symptoms, you should suspect, the doctor should suspect a DVT in the pelvic area, because it can actually happen here, which is definitely harder to diagnose. Just the thought, food for thought. So what are we going to see? Tenderness, redness. Always good to compare one extremity against the other, right? See if there's any difference. Low-grade fever, Homan sign, and Homan sign is kind of iffy. If they do have a blood clot, just haven't flexed their leg, I feel like push that clot. So I kind of worry about that a little bit, but they're still having us do that. But definitely it'd be a positive sign. So when you have that mom push their foot back, and they have pain, and I would say not stretching, but pain, sure pain. That can be a sign. And we're always checking their pulses, make sure they're good. And a decreased peripheral pulse, pedal pulse, could also indicate that. And you can get venous thrombosis anywhere, but typically they're in the legs. Okay. Management. Early ambulation, as I said. If they are diagnosed with a DVT or a superficial, they will be started on anticoagulants, heparin, Lovenox, and then when they go home, they'll start on Coumadin, and then when they reach a PTT or an INR, I should say, of 1.5 to 2, then they can send them home. They'll monitor that really closely. So Coumadin is usually what they go home on. Although there have been some patients that go home with Lovenox if they're not afraid to give themselves injections. So they're usually kept on that for 2 to 6 months. 2 to 6 months, yes. Rest with elevation of the affected extremity. They used to really push the strict bed rest, but they kind of let up on that. They let them move around more than they used to. It's good to talk about herbs to avoid, like ginkgo, garlic, and ginger, because they increase the PTT time, which is, in other words, they thin the blood even more. They may have elastic stockings, heat, and my wood refugees are the ginkgo, garlic, and ginger. Okay. Get to postpartum. postpartum depression. Okay, anybody know anyone who's been through postpartum depression? Really? Okay. Oh.
Like 6 years ago.
Okay. Laura knows someone who's still struggling, and then Bernadette said she did a little bit, if you don't mind telling everybody. Too late for Bernadette. Sorry. So, all moms, not all moms, a lot of moms, I know I did, get baby blues afterwards. I'm happy, I'm thrilled, and I'm sitting there crying for no reason. So a little bit of postpartum blues is normal, and so postpartum depression is more than that. Okay, this is different. It's intense, pervasive sadness or severe mood swings. So like the postpartum blues should go away within a few days. If they last longer than that, and you're just so depressed and you don't really want anything to do with the baby, it could be postpartum depression. They may have intense fears or anger, anxiety, just despondent, they're just really labile, and just uncontrolled sobbing. And this usually doesn't happen until like the first month, after the first month. It occurs in 7 to 30% of new moms. That's pretty high, isn't it? 7 to 30% of new moms. And they rarely disappear without help. What is our main concern with this? Safety of the baby. Yeah. I mean, because sometimes they can get into hallucinations and, think very bizarre thoughts and hurt the baby. So it's something we always tell our moms about. Risk factors, first-time moms. If they were not on board totally for the pregnancy, if they've had a history of psychiatric disorders, and lack of support, and low self-esteem, also makes moms at risk, higher risk. So this definitely requires medical management, mental health support. They need psychotherapy, antidepressants, and lots of support. Typically, SSRIs are selective serotonin reuptake inhibitors, or antidepressants that we go to. They may have to be on lithium or antipsychotics. They're really severe. Good thing is they have support. Lithium, yeah. Sometimes lithium. What do we typically use lithium to?
Hallucinations.
Yeah.
Or what?
Antipsychotics are with We'll get to that. So, these moms, if they don't have assistance, try to get them assistance, help. It's hard to be a single parent. And if there is danger to the baby, then possibly take the child from your care. I'll just go through the next slide. This is a bunch of stuff. Okay, so at first we talk more about those are done at 1 minute and 5 minute and more if baby's distressed, and we'll talk more about what's looked at, but we're looking at heart rate, respiratory effort, muscle tone, reflex irritability, and color. So a lot happens in delivery. Blood flow from the umbilical veins and placenta stops. Closure of all those ducts, which you guys talked about and tested on, right? Ductus arteriosus, the foramen ovale, and cyanosis, which causes increased pulmonary circulation to happen because now baby has to breathe on their own. You may hear murmurs in our newborns, and because sometimes those ducts don't totally close all the way. It's very normal to see acrocyanosis. That is a normal finding in our newborns. Everybody know what acrocyanosis is? Hands and feet are bluish, and it's just their peripheral circulation is sluggish when they first are born. So that is not anything to worry about, and that should improve. Heart rate, you're going to see different ones. 120 to 160 is typically what I go by for the normal heart rate. Can be as low as 110 if they're in a deep sleep. So anywhere from 110 if they're sleeping to 160. If it gets to be above 160, we're concerned. If they're awake, we want it to be about 120. Yes.
Up there in the top, it says sleep. What hours a day?
20 hours a day, and it sure doesn't seem like it. If you've ever had a newborn, it doesn't. Yeah, 20 hours a day for the first 2 weeks. Yep. We have to remember that babies come out wet, right? So we've got to dry them off quickly, put them in a warm environment. We used to take them from the doctor, put them on the radiant warmer, dry them off. But now what are they doing? Giving them to mom. Typically, they try to wipe them off a little bit and then give them to mom. We've seen both things happen. But you really want to get that moisture off, okay? Because they can lose heat through evaporation, and then cool air hits them from convection. Induction is body heat to blankets, cold blankets. So babies up next to mom's chest, which is warm, so that's going to help. And then heat loss due to radiation or cool temperature. So we've got to make sure we monitor the temperature of the mom's room. Yes.
I was gonna say my nurse offered a choice to the mom. Do you want us to do a quick wipe and then give them, or actually dry them off and then give them, or you want them as soon as possible? So she got to choose, and she was like, "Oh no, you can clean them off."
Please. So what they do in that case, they just put them on and then they kind of wipe them off as possible. Most moms want that.
Yeah.
Most moms. No. So the big thing is we don't want these babies to get cold stressed. Okay? With chilling, they use more oxygen. They have to have more glucose, so they use more glucose, which causes hypoglycemia. This says less than 45. Last I looked, it was less than 40, so we're going to go with less than 40. Okay? And brown fat, so we're going to burn that brown fat. So they're going to need more calories, they're at risk for metabolic acidosis, decreased surfactant production with chilling, so we don't want our babies to get cold. It's very important. So what do? We dry them off, we put them next to mom, put a hat on, we put blankets, a couple blankets, we swaddle them up, okay, until they can get used to keeping their own temperature up. Just some general characteristics. Typically, babies are 19 to 21 inches, 7 pounds, 8 ounces. Typically, average, I guess I should say. And the big thing is with babies, they lose 5 to 10% of their weight in the first few days, and the doctors don't worry about that. If by say the third day, they've lost more than 10%, they start to get concerned. So typically, if they discharge them in 2 days, 3 days, they'll have the mom bring them back in for a weight check, color check. We're going to talk about jaundice. So they check for their color and also to make sure they're not losing too much weight. But then they should regain it in 2 weeks. So then they also have a 2-week checkup. Molding, everybody know what molding is? So the cone head, anybody watch Saturday Night Live cone heads? Yeah, right? But yeah, they look like little cone heads when they come out, and that's called molding. Capid succedaneum. Remember what I said about that? That's the edema, the swelling. It's like a cap that sits on top of their head. It crosses the suture lines, where the cephalhematoma does not. So you may see a big lump on one side of their head or both sides of their head. And if it doesn't cross the suture line, then it's a cephalhematoma. Okay, some other measurements. Fontanelles, we're checking those, right? You want to make sure those fontanelles are flat. You don't want them bulging or sunken. Bulging means what?
Increasing intracranial pressure.
Intracranial pressure, and sunken means
Dehydration.
Dehydration. Good job. So extremes and sizes. If it's extremely small baby, microcephaly, or not small baby, small head, or hydrocephalic is a large head, and it can indicate, well, the microcephaly could be just their brain development wasn't what it should be. Hydrocephaly is where there's increased growth, which increases intracranial pressure. Remember AVA? So right after delivery, you want to check for the two arteries and vein. They may get a cord sample. What they're doing now at Rowan is we have such a large population of drug abuse, even in our moms, they cut off part of the cord and send it for analysis, and that cord will tell them whether that baby's been subjected to any drugs during pregnancy. So that's kind of just throwing that in. Lung function after 26 weeks, there's some function, but the surfactant isn't good until about 35 weeks, and they need that so those alveoli don't stick together. Did anybody go to the intensive care? Yeah, Ms. Collins didn't let you guys.
They wouldn't let us go unless we asked, but they wouldn't let us go into the NICU.
Oh, that's new. I wonder why. Did they say
Probably
what?
risk of infection.
Gotcha. It was a bad ear infection. Oh, I'm so sorry. Because that's fine. But in our preemies, if they're less than 35 weeks, sometimes they'll give them surfactant at delivery, and that helps them have less respiratory depression or distress. So yeah, what do we want to see in the first minute? We want our babies to be loud and less cry, no difficulty, retraction. I'm getting worse now. Respiratory rate 30 to 60. And you can see circular cyanosis, and that is also a normal finding. I'm done. Anyway, if it's extreme, you can be concerned, but a little bit of circular cyanosis is okay.